Okay, let us begin now to discuss the more common medical emergencies you are likely to encounter during day-to-day clinical duties in the dental practice. The order in which I'm going to present these are completely random and do not follow any specific order, such as the frequency of occurrence in practice, for instance. In fact, the frequency of occurrence may vary in different clinical settings and in different geographical locations. The very first emergency to consider in our case is chest pain, and the common causes of this are the ischemic heart diseases, angina pectoris, and myocardial infarction, both of which are cardiac related and must be dealt with as promptly as can be. The symptoms of these disorders are quite unique. However, the problem arises when it comes to distinguishing between the two. As if that was not enough, a number of non-cardiac chest pain disorders may equally mimic ischemic heart pain, and so it often is useful to rule out these other differential conditions so as to narrow your attention down to the more acutely life-threatening cardiac-related pain syndromes. The two common non-cardiac pain pathologies to rule out are referred upper abdominal pain from gastrointestinal reflux disease and then external chest pain from costochondritis. The pain of costochondritis can be easily reproduced by simply gently palpating the inflamed costochondrial joint because it is completely a chest wall pain disorder and has no relation intrathoracically. Reflux diseases will often respond to antacid medications, and this can be both diagnostic and therapeutic. With that said, if at any time you are unsure of the specific chest diagnosis, treat always as a cardiac-related condition until you have proven it to be something else. Let's focus our attention now to these cardiac pain disorders, angina pectoris, and myocardial infarction. There are a number of variants of these conditions, and all will fall under the acute coronary syndromes. Patients who have angina pectoris, for instance, may either be suffering from unstable angina, stable exertional angina, or prince-mental spastic angina, and those with myocardial infarction or MI may either have ST elevation or non-ST elevation MI, depending on changes observed after electrocardiographic studies. In the typical scenario, a stable form of angina is not considered an acute coronary event since it is a more chronic and stable condition that only comes on after some sort of physical exertion. But we will ignore this categorization for the purpose of this lecture. There are well-established risk factors that predispose one to developing these coronary events, and some of these will include smoking, the male gender, diabetes mellitus, peripheral arterial diseases, abnormally high cholesterol levels, and a positive family history of ischemic heart disease. In the clinic setting, anxiety and pain are known aggravators of pre-existing anginal disorders, and so keeping these to a minimum, either with anxiolytics or effective analgesia, will highly influence the frequency of these events occurring. Like I alluded to previously, the symptoms of these events are often clinically indistinguishable and for the most part are the same across board, with a general pattern of substernal crushing chest pain occurring either spontaneously or precipitated and aggravated by physical exercise or emotions. If at any juncture you are in doubt of the reason for a particular patient's cardiac chest pain, assume it is one of these myocardial infarctions until you can prove it otherwise, because obviously these are more life-threatening. The typical location of cardiac-related pain is somewhere halfway between the chest. However, not all patients are able to localize or point to this exact location, and some will use broad hand gestures instead. In such situations, combining these gestures with the pain pattern and descriptive words used by the patient may help, but again, if you are in any doubt of the cause of the pain, manage as an MI. If not, you are at risk of losing that patient within the first hour if indeed it is an MI. I repeat, if you are unsure of the reason of a cardiac-related chest pain, treat it as a myocardial infarction. A typical hand gesture made by patients is a clenched fist placed over the center of the chest, the so-called Levine sign, and is a good indicator of ischemic cardiac pain, at least generally. In certain cases, instead of frank pain, some patients may complain of a heavy non-specific discomfort in the chest or a feeling of constant external chest pressure which radiates up and down the left arm, to the shoulder, center of the upper back, the neck, throat, and left mandible, which may indeed present as a deep-seated toothache. It is worth noting that cases of unstable angina or Prinzmetal angina as opposed to stable angina often occur unprovoked by exercise and may even occur when the patient is at rest, just like myocardial infarction. In the same vein, the symptoms of unstable angina and the types of MI often last longer than that of stable angina, and they also do not easily get relieved after nitroglycerin vasodilatory therapy. The main reason for this is because in stable angina, unlike unstable angina or MI, that is the typical acute coronary syndromes, the coronary vessels that supply the blood to the contracting heart muscle are only partially occluded, and symptoms occur only when there is an increased demand, such as during a stressful activity, fear, flight, fright, and so on. So therefore, to relieve this, you either reduce demand by resting the heart muscle or increase blood supply by vasodilation of these coronary vessels, at least in theory. In the typical acute coronary syndromes, the inadequacy of the coronary circulation is much more severe, and so treatment is not as straightforward, and getting the patient to a hospital facility will be the prime goal of the dental team. Now, some other additional symptoms that these events may cause include nausea and vomiting, which may be pointers to myocardial infarction, palpitations from compensatory sympathetic activity, patients may become sweaty, cold, and clammy, acute confusion, fever, tachycardia, or even bradycardia. Bradycardia will occur when there's extensive heart damage and may result in hypotension or systemic shock. Hypertension, again from compensatory sympathetic activity, or even hypotension in severe myocardial infarction, and this also is a reason for the nausea and vomiting some patients may experience. The explanation is because of a reduced blood supply to the so-called vomiting center in the brainstem, that is the area postrema. Breathlessness, dyspnea, and symptoms of indigestion are also not uncommon. But a third of patients may be completely asymptomatic, suffering from the so-called silent myocardial infarction, and this is especially common in those with diabetic neuropathic complications or those taking medications that may mask some of these symptoms. As you would probably have noticed, a complex of this symptomatology could equally be observed in a variety of other chest pain conditions, and it becomes critical that you distinguish between these other chest pains, some of which, in fact, majority of which are non-cardiac related. We initially mentioned reflux disease and conchocondyritis, but on a more comprehensive note, we will systematically group these into three main classes: cardiac-related pain, pain of respiratory origin, and pain of gastric origin. Under cardiac-related pain, we obviously have the anginas and myocardial infarctions, but also pericarditis, which may either be a fibrinous or exudative inflammation of the pericardial covering of the heart. In severe cases, it may constrict the heart and limit diastolic filling, thereby leading to cardiogenic shock. Then there is myocarditis, or inflammatory cardiomyopathy. This one is related to infections or certain toxic substances like chemotherapeutic agents, of which doxorubicin is a prototypic example. But also, overindulgence in alcohol is a prime risk factor. It could also be a manifestation of certain autoimmune diseases like lupus, sarcoidosis, and so on. The final member of these cardiac-related pain syndromes is aortic dissection, which is a devastating event, usually of the thoracic portion of the aorta, in which a tear in the luminal wall allows blood to track within the thickness of the muscular wall, and this causes a sudden and constant chest or upper back pain described as ripping in nature. It may be a complication in patients with severe hypertension or atherosclerosis, or in individuals with genetic connective tissue disorders like Ehlers-Danlos or Marfan syndrome. If it happens, a useful clinical sign is that there may be an equal blood pressure measurement or peripheral pulses in both upper limbs. For the respiratory-related chest pains, we have pulmonary embolism, pneumothorax, pneumonia, and pleurisy. Some of these we will discuss in later lessons of this course. For gastrointestinal related chest pain, it will mainly have to do with the esophagus, hence reflux disease as we mentioned before, and then diffuse esophageal spastic disorder or diffuse esophageal spasm. This one is a motility disorder that not only presents as a substernal chest pain, but also often occurs together with symptoms of dysphagia, and in fact may coexist in some cases with reflux esophageal disease. The spasm that occurs, interestingly, may also respond to nitroglycerin, since nitric oxide, an endogenous vasodilatory molecule, is thought to be locally deficient in this disorder. However, typically, the first line of treatment mostly involves the use of antacids like the proton pump inhibitors, omeprazole, lansoprazole, and so on. It is diagnosed by performing an esophageal manometry, which measures the intraluminal esophageal pressures. The next class of non-cardiac chest pain mostly comprise pain of musculoskeletal origin. Trauma-induced pain, which may be from rib fractures, and also costochondritis, or so-called Tietze syndrome. This is commoner in females and can affect any costochondral joint. It may be from trauma, physical stress, infections, or even tumors in the local vicinity of that particular costochondral joint. The pain occurs typically with deep inspiration as the chest expands and also on moving the upper body. As a result, patients may experience shortness of breath as a manifestation of restricted maximal inhalation. You can diagnose by gently palpating for the affected joint and eliciting local tenderness. Alright, let us move on now swiftly to look at the management of cardiac chest pain emergencies in the dental setting. As we alluded to earlier, the initial management of angina is quite straightforward provided you have made the correct diagnosis. The aim is to relieve pain and, if needed, transfer the patient to a hospital facility as soon as is practically possible. The management for myocardial infarction aims to keep the patient alive and relaxed as long as is possible until hospital help arrives, since there is a chance of cardiogenic shock, life-threatening arrhythmias, and cardiac arrest. Regular pulse checks can alert you to the development of these complications. In both instances, whether angina or myocardial infarction, most conscious patients will be more comfortable in a sit-up position or semi-fowler position. However, if patient becomes unconscious or becomes hypotensive, then placing them in a supine and Trendelenburg position with their feet elevated is imperative. This allows restoration of blood flow to important sites like the neurons of the brain. It is imperative that during an emergency that you make the patient as relaxed as possible and stop all clinical procedures. Making the patient relaxed means you, the dentist, must also be relaxed and avoid any panicky behaviors. This can only become easy if you regularly drill yourselves through these emergency procedures until you become more comfortable with them. Anyways, make the clothing around the neck area loose. For instance, by loosening a tie or disengaging the first two buttons on the shirt. A controlled oxygen therapy is helpful if the patient becomes short of breath or when their oxygen saturation falls below 94%. The O2 saturation can be checked using a portable pulsimeter and is very handy in the dental clinic in both emergency and non-emergency situations. Oxygen therapy should be given usually as 3 to 6 liters per minute flow rate. Administer transmucosal nitroglycerin spray or tablet sublingually, usually as 0.3 to 0.6 milligrams, and you may repeat these every 5 minutes depending on the initial response. The patient may have his or her own medication and you should allow them to use it if they are willing to. In anginal cases, the pain should alleviate after the first or second nitroglycerin therapy. If this is not the case, that is, if the pain has not subsided, then you are most likely dealing with an MI and hospital emergency services must be summoned immediately. Sometimes, in a patient with previous numerous anginal episodes, an MI attack will feel much worse and he may alert you to this fact, which should then give you a clue as to the seriousness of the condition. In fact, the patient may ask you to call the emergency services as this does not feel like his or her garden variety angina pectoris. You must respect this request. In the meantime, whilst EMT services are on their way, administer aspirin 300 mg tablets or other antiplatelet medications if the patient is intolerant to aspirin. If possible, general analgesia like 2.5, 5 mg or even 10 mg of morphine tablets may as well be given to not only relieve pain but also as an indirect way to relax the patient. Morphine usually will be administered with an antiemetic like 10 mg of metoclopramide to counter its nausea side effects. Vital signs should be monitored throughout. Oxygen should always be given, and it is important to document all medications administered so as to provide the correct information to the emergency services when they arrive. On that note, we come to the end of this lesson. In the next lesson, we will be looking at the management of acute asthmatic attacks in the dental setting.